Welcome to Sports Ophthalmology, a podcast for ophthalmologists and trainees interested in providing eye care to athletes. I am your host, Jared Tuttle. Join me as we hear from national leaders in this exciting subfield of ophthalmology. We are looking to expand our team. If you are a medical trainee interested in furthering the conversation on sports ophthalmology, please click the link in the bio or on our website, sportsophthalmology.com. Dr. Jennifer Yu is a comprehensive ophthalmologist in Seattle, Washington. Dr. Yu received her bachelor's degree at the University of Michigan and her MD, PhD from Washington University School of Medicine, where she also completed ophthalmology residency. Dr. Yu currently serves as a Director of Trauma and Consult Services for Ophthalmology at Harborview Medical Center. She is passionate about resident education and is a board member for the American Society of Ophthalmic Trauma. All right, Dr. Yu, thank you for joining us on Sports Ophthalmology.
Thank you for having me. It's such an honor.
So you have experience across different areas of ophthalmology. What has drawn you to ocular trauma care?
Well, like a lot of things in life, it is something that was unpredictable. So I joined the faculty at the Department of Ophthalmology at the University of Washington many years ago now. And I didn't really realize it at the time, but the main hospital that we are affiliated with, which is Harborview Medical Center, is renowned for its trauma care. And so because of that, our Department of Ophthalmology does a lot of trauma. And I think as part of that, it just naturally was something that I kind of fell into. Like I said, a lot of things in life are unplanned like that. And so the more trauma care that I did, it became more interesting to me. A few years ago, I became the Director of Trauma and Consult Services for our department. And that really gave me more of a bird's eye view and a window on all the different ophthalmic trauma that we see. And I realized that that was very fascinating. And there are also a lot of aspects of trauma care that we don't really know and are good areas to explore for research. And also the third mission of any academic department, of course, is not just clinical care and research, but it's also resident education. And so I also realized how valuable having that trauma experience was for our residents and for learning principles of ophthalmology.
What does your role as Director of Trauma Services entail?
So, like I mentioned, our hospital, Harborview Medical Center, I'll just give you a little bit of background to kind of set the setting. So it is the only level 1 trauma center in a 5-state region. So we are located in Seattle, Washington. We are part of a loose educational and hospital network of the 5 surrounding states. So it's Washington, Wyoming, Alaska, Idaho, and Montana. And we're the only level 1 trauma center of those 5 states. And so we don't necessarily get all the trauma from all of those states because a lot of them will go to their neighboring states, but we do get a lot of trauma from the Pacific Northwest. And interestingly, we also get a lot of trauma from Alaska. There's not many ophthalmologists in Alaska. And so our patients tend to be from a very large geographic catchment area and also a really good mix of urban in Seattle, but also very suburban and rural, as well as a lot of the industries that are here. So the fishing industries in Alaska, et cetera. Now, kind of narrowing down the Director of Consult Services, Trauma and Consult Services, I oversee the residents when they see the trauma patients and the inpatients in the hospital. Our system is divided into kind of the night weekend call system that a lot of academic places are familiar with. And then we also run a daytime trauma and consult service. And so I am supervisor for the daytime trauma and consult service. I interact with the other subspecialties in our department, as well as the other departments in the hospital, such as the emergency medicine department, the hospitalist, the neurologist, all the other things that we might collaborate and to help take care of these patients. And then I also work with our program director in supervising the residents and coming up with educational content that would be helpful for them as they go through our rotations.
That's great. As I've spoken to different ophthalmologists, it seems like many go into the private practice intending never to touch trauma again. In your experience, is it generally the academic centers that handle the trauma burden in an area? How involved are private practice providers? Do they take calls sometimes? Does it just depend on the situation of the city that they're in?
Yeah, that's a great question. So I think it's highly variable depending on the geographic location, and even within a city, there might be pockets that are different. And it's a very rapidly changing healthcare landscape. And so I think across the country, there are fewer and fewer community private practice ophthalmologists that are taking call in general, and especially taking trauma call for their local hospitals. Not to say that there are not, but it is highly variable, just depending on each. Almost, it's a physician to physician decision almost. Hospitals are recognizing that they need to have ophthalmologists available, and so some of the hospitals have started to pay, extra for ophthalmologists to take call, but that is nowhere near, widespread or everyone. But it is a new trend that's happening. So then, as a result of that, we are seeing fewer people take ophthalmology call for hospitals, and then those smaller community hospitals are then transferring patients to the larger academic center hospitals. And I think that's happening throughout the country too.
So the trauma referrals that you're getting, is it generally from an emergency medicine physician, or what percentage are from ophthalmologists that are sending to you?
Well, we have, our hospital has a very standardized protocol for these things. And so for individuals who want to send a patient for an ophthalmology evaluation for trauma, they oftentimes will need to go through our what we call our contact center, which is just a center to field these phone calls and make sure that they get transferred to the right person. Certainly, any emergency medicine doctors in an outside hospital or urgent care, then they are required to go through this transfer center. And it's a very standardized, hopefully smooth process where they call the contact center operator, and then they know how to get in touch. They have our call schedule, so they are able to contact the correct person, transfer that, relay that information, and then a very integrated process, also communicate with our emergency department so they can expect that patient to come to our ED.
So suppose I'm in Alaska and I have a fishing incident. Fishing is a sport. I'm an angler, and I
Yep,
have
for
a fishing
sure.
incident, fish hook in the eye. What goes from there? Maybe I go to the urgent care, and then
Mm-hmm.
from there, what happens behind the scenes?
Yeah, so that's a situation we do see all the time. A lot of the I will say a lot of the commercial fisheries, it's not necessarily a fish hook, but we do see our share of fish hooks. So they would go to their local, urgent care or hospital emergency department. That physician would call our contact center, our call center, talk to the operator. They would call our resident who's on call, either daytime or nighttime, give them all the information. The resident provides some triage, may ask some questions. And then if they feel, review any imaging, usually the emergency department physicians, especially in those rural, faraway areas, they're usually quite good at evaluating the eye, evaluating to see what are the red flags that might require, more higher level care. And so, and then now with telemedicine, they can take a picture of the front of the eye, and sometimes they even have a fundus camera. They can take a picture of the back of the eye, send that to the resident on call. They can review any radiology images, a CT scan if there's an orbital fracture. And then if we decide that the patient does require an evaluation with an ophthalmologist, then we would ask that the patient be transferred. We would also pretty seamlessly, again, be in contact with our own emergency department so that when the patient arrives, they know that they're there for an eye condition, and that they're not spent waiting for hours in the waiting room while they're waiting for ophthalmology, that we are expecting them. In the case of patients in Alaska, this happens quite frequently. They are airlifted to our hospital.
So, what kinds of sports-related ocular trauma have you seen in the emergency department?
Yeah, great question. So I will, just like what you said, fishing is a sport. I will expand the definition of sports related to include, not just organized sports or even individual sports, running, cycling, but also recreational activities. Just like you said, fishing is certainly a sport. We see a lot of fishing injuries. BB gun, airsoft gun, that can be a sport. I've seen a bow and arrow injury before. But those are still relatively uncommon. The most common things that are seen in the United States are basketball, baseball, softball, and then air gun injuries actually. Our patients are a little bit similar to that in terms we do see our share of baseball, softball, basketball, as well as BB and air gun. However, in this area, we do see a lot of soccer. We see a lot of golf. We see a lot of racket sports, which is just in general, tennis, racquetball. We're starting to see increased number of pickleball injuries. I know there's been a couple of articles about the rise of pickleball injuries, so we've seen those too. And, people here, I imagine everywhere in the country, but people here in the Pacific Northwest, they're very active. We have weather that allows outdoor activities year round. And so all the more chances for injury, unfortunately.
So, what kinds of injuries should be taken care of in the outpatient setting versus what kinds of referrals are you really glad that they're getting referred to you and they're not just getting turned away at the urgent care or sent home at the urgent care?
Yeah, so that's a great question too. I feel like from the patient perspective, it's very difficult to determine, if this is something that needs to be seen right away or if it can wait until an office visit. The damage or the injuries that come with sports-related injuries are just like with any other trauma. They can range from more mild, corneal abrasion, self-limited, subconjunctival hemorrhage, to things like a hyphema, a lens dislocation, a vitreous hemorrhage, and certainly, we see several open globe injuries. And so from the patient perspective, certainly anything, the warning signs that would be for any type of vision, severe issues, loss of vision, blurry vision, loss of peripheral vision, new floaters, flashes, eye pain. With orbital fractures, we're worried when patients have double vision or nausea and vomiting. However, so that's at the patient level. In the urgent care level, again, I think most urgent care physicians are fairly reasonable at looking for corneal abrasions and subconjunctival hemorrhage, and so we don't get a lot of phone calls for that. Things that may indicate open globe, certainly, 360 degrees of bolus subconjunctival hemorrhage, a peaked pupil. If they see any hyphema, we're always willing to see any of those patients. Bulbar hemorrhage. And so I think all of those are very reasonable to at least call and get an evaluation.
So I feel like you're in a unique position. You see a lot of this sports-related ocular trauma. In your opinion, what are some of the most important next steps for injury prevention?
Yeah, that's a great question. So, it's really hard to see these injuries happening. And a lot of them, you think it could have been prevented, right? If the patient had done X, Y, or Z. And so, the one thing that really has been shown in the literature time and time again is just eye protection, safety glasses, eye protection. It does need to conform to the what we call the ASTM, or what is called the ASTM requirements, so the American Society for Testing and Materials. So they have specific requirements that are different for different sports. Interestingly, it's been shown, like I wear glasses just for vision. A lot of people wear sunglasses when they're out doing sports. It's been shown that, just regular glasses can actually cause more injury because the glass shatters and then that can cause laceration. And so they really need to be, up to that safety level. Now, the difficult thing is getting that, to be widely accepted and implemented. And there's a lot of barriers to that. I think a lot of that is, maybe people don't know that there can be devastating vision loss with injuries. A lot of the injuries happen in children, and so they're not necessarily thinking about these things. And then there's also some belief that the safety glasses or safety goggles can actually cause some limitation in vision. I think a lot of the pro athletes don't like wearing them because they think it interferes or they fog up, they're uncomfortable. And so I think there is a lot of education that can be done about that. There's also, not just education to the general public, but even to the policymakers and the organizations. The NHL is one great example where they realized that this was an important thing and they started mandating the visor use to protect the eyes. And the studies have shown that the eye injuries have greatly decreased after that. And so certainly, the policy can be changed, just public education, and then, making the safety glasses more widely available, affordable, better materials, comfortable, all those things I think can be easier said than done, though.
Right. In your opinion, is there like a specific research study or just types of research studies that are necessary? Do we need to be characterizing the types of injuries that are happening more frequently? Or is there plenty of data out there? Do we know what's causing all of the most amount of trauma?
Yeah, there are some good research studies that have been done through the years. Recently, there have been some epidemiological studies using national databases with ED patients and injuries. There's been studies looking at various sports. Actually, I wanted to do a little preparation for this podcast, and so I read some very interesting articles about surfboard injuries and, of course, pickleball we mentioned. Oh, elastic bands. I thought that was very interesting. And so I think, but that's just like one review article or one case series here and there. There have been more studies on, the more popular sports, basketball, football, soccer. But I think that, we always need more information, and also that things are constantly changing. You can't rely on studies that were done, 10, 20 years ago. And I think it's well shown that the protective eyewear can help, but I think, as it applies to each sport, I think that can be very interesting as well.
Right, like within each sport, I was even talking to an ophthalmologist that like within each position, for example, the needs of a football lineman might be different from a football receiver or a quarterback, so.
Yeah, exactly. Yeah, I agree. And actually, it was interesting. I read an article with the NFL, and they said that, or I'm sorry, the NBA, and they said that most of the eye injuries occurred in the fourth quarter and occurred in the paint. And so I thought, well, maybe, if they don't want to wear the safety glasses the entire game, maybe just the fourth quarter. I don't think that would
Yeah,
get that much traction, though.
right. So we talked a little bit about education and that aspect to it. Is there a specific need for more ophthalmologists providing ocular trauma care?
Oh, 100% we need more ophthalmologists who are interested in trauma care and willing and able to do trauma care. Just like we alluded to earlier, there are fewer and fewer ophthalmologists taking call. And I think that's due to a wide variety of reasons. It's not any single thing to point the finger at, but just having ophthalmologists feel comfortable about it, having the hospital recognize that this is an important thing that they should provide, just compensation for, as well as provide the facilities. I think ophthalmologists who go to the hospital and see patients, but they don't have any ophthalmology equipment, that's not a very good use of patient thing for patient care either. So it goes, certainly we definitely need ophthalmologists who take trauma care call. And then also the hospitals, I would hope that they want to put a priority on that as well.
So suppose there's a medical student interested in trauma care and they're hoping to find a program that gives good trauma education. Do you think that is accessible in a variety of programs or in a select few of programs? I know, for example, like penetrating globe injuries, globe repairs, the minimum is 4. Is that enough to come out of residency feeling like you can be a comprehensive ophthalmologist and assist in providing trauma care?
Yeah, so I think that if a medical student is interested in ophthalmic trauma, then there are certainly some programs that do have a little bit more exposure to trauma than other programs. And I think it's probably pretty easy when you're talking to the residents to figure out which programs those are, the programs that are used. Certainly our program is very, very heavy on the trauma care. Um, as to your question, so for 4 globes, that is the minimum that's required. I think that the the globes and any kind of trauma care. The thing about it is that every case is different. Every single patient has a slightly different injury and a slightly different situation. And so, even if you did 40, which I believe that maybe some of our residents have done, you're still not going to be prepared for every single situation. But if you are taking advantage of all the experiences that you can get, and there are a lot of also available resources, like through the American Society of Ophthalmic Trauma, and take advantage of those and perhaps have a mentor that you could call. I think that would be, you know the basic principles of closing the globe. And also it's just basic suturing principles as well. There's nothing special or there's not a unique equipment that you need to use to close the globe. And so I think, hopefully anyone would be able to feel comfortable doing that. I think more, not so much the lack of skill or experience, more the barriers are to do with facilities and equipment and disruption to their normal clinic day and compensation. And I guess, and trauma is not just the open globes either. There's a lot of others, hyphemas. So some of those that, possibly could be more easily managed by the community ophthalmologist, the hyphemas and the traumatic uveitis, and even some of the orbital fractures that don't need urgent repair. Those could certainly all be seen in more of an outpatient setting, but just evaluation usually needs to be done more urgently in the ED.
So speaking to athletes when they have an injury, first question is, when can I get back? When can I go play again? And so for, corneal abrasion, maybe something more simple that might be an easier conversation. But for the patients that are routinely sent to you that you're working with regularly, what kind of conversations do you have with those patients?
So for the athletes, we it's the same regulations that we would have for any patient depending on the injury. So certainly for the hyphema, we do want them to be extremely light activity for, the first week to 2 weeks to prevent the rebleeding. So athletes, depending on what level they are and how competitive they are, it may take a little bit more stern recommendations than the general population. Um, but I think that, if you frame it in terms of what's best for the health of your eye and for your future vision, then everyone is understanding. And we always are happy to write letters for the school or the sports organization to explain that as well.
What's the visual prognosis like? If they, they're like, am I going to be able to see again? Are they going to be functionally monocular from there on out? I know it probably depends on the injury, but in general.
Yeah, definitely depends on the injury. So, luckily, the epidemiology studies have shown that the vast majority of sports-related eye injuries are more on the mild side or more self-limited and have a very good prognosis and good outcome. Most of them, the corneal abrasions and even the conjunctival lacerations, the hyphemas, oftentimes those heal very well. There are a certain subset that have a risk either immediately from permanent vision loss or down the road. And so the ones that need monitoring that can develop vision loss are the ones that are often associated with hyphema, so angle recession, developing glaucoma, uh, or developing a cataract. Um, and then, of course, there's the ones that have immediate vision loss. And so those are the most devastating, of course. We see a lot of open globe, but we also see a lot of traumatic optic neuropathy. They get hit really hard on the brow, and there's a coup contra coup force that's transmitted through the orbit into the optic nerve, and sometimes they don't do well after that. And so it is a very difficult conversation to have with a patient. When we first evaluate them, of course, we're focused on treating their, initial problems and kind of getting them through that area. But then the conversation then evolves to, what can we do? What's the visual rehabilitation like? And again, depending on their injury, the open globe injuries, many of them are devastating, but some of them, maybe they require another surgery, a retina surgery. They need some specialty contact lenses, but some of them have actually reasonable vision. And then how it affects their sport, that also depends. What we do make sure that we tell every single patient that has had a CDI injury is that tissue is not compromised, and that they absolutely need to be wearing safety glasses for any activities. Because once that tissue, even though it's been healed, that can be the focal point for any future injury and open up again. So safety glasses for everyone.
Yeah, and I feel like that's like the data shows that individuals that have had an eye injury are most likely to wear injury prevention eye protection.
Yes, yes, yeah, and that's a great thing. And we have seen patients who've had an eye injury or even just not just or previous eye surgery, a corneal transplant, cataract surgery, and they get hit on the eye, and if they are wearing the safety glasses, that makes a huge difference.
So you mentioned ASOT, the American Society of Ophthalmic Trauma. What has been your involvement with ASOT, and what advice do you have for trainees interested in trauma care and getting involved with ASOT?
Oh, great. I think ASOT is a fabulous organization. It is only founded since the year 2020, or there was a reorganization in the year 2020. And so I think that it is, a lot of the members are very passionate about it. And there's a lot to do because this voice has been missing in our national discussions on policy and eye protection and eye care. And so I think that there are a lot of opportunities to join and to help out. I think they're always looking for help. My participation is that I've been a member, I think probably since 2021, with my involvement with my job as Director of Trauma and Consult Services. I wanted to get involved at more of a national level, and so I approached the board, and am very honored and lucky to be part of the board now. And I know that they do a lot of great things. They have a symposium at the American Academy of Ophthalmology. They have their own annual meeting this year for the second year in person and for the first time with a wet lab. So that is very exciting.
Great. Yeah, that'll be in Houston in May. Is that right?
Yes, that's right. I think May 17th and 18th, perhaps. I'll give a shout out. I think, are they still taking registrations? It's a great meeting.
I think so.
Yeah. And I think I will say that one of the things I really enjoy and value about ASOT is that it's a pretty small organization. It's not one of those huge national ones where there's 20,000 people there and you don't know anyone. It's a very small organization. The people who are in it care deeply about this topic. And so it feels really great to be involved in something like that.
So I really enjoyed your insight on the fourth quarter of basketball having the most eye injuries. And so if you're not wearing it all the time, then maybe in the fourth quarter. I think that eye injuries can be seen as something like a freak accident. Like, oh yeah, like I've never had that. Like I've never seen anything like that. Oh, but this one time this thing happened and someone's eye got really hurt. And so it can be a hard sell to have someone wear eye protection every time they go play when eye injuries don't happen every single time. Whereas maybe
Yeah.
like an ankle injury, those happen often enough. You can convince people to wear braces. You can kind of figure out ways to prevent it. And so
Yeah.
so what are some of the times when injury is most imminent, that if
Mm.
you're going to wear eye protection, that is the time to wear it?
Oh, yeah, that's a great question. So, I find it very interesting to think about sports injuries and how, when, and why they happen. Um, and there's a number of different factors that have actually been looked at for this. And so, one of the things that determine, the injury and the extent of the injury is, first of all, usually the injury is from some object colliding with the eye. And that's not always the ball in a ball sport. That can be a finger, an elbow, it can be a golf club. Um, I was surprised to read that a lot of the injuries in golf actually are not from golf ball or the golf club, it's from the environment. And so, like falling, tripping on something. We actually had a patient where they were struck by a rock. Maybe a piece of rock flew up when someone swung their, hit the ball. A rock hit their eye, caused an open globe injury. And then we've also had a patient that had a golf cart injury, orbital with a golf cart. So a lot of that is not even related to the, implements of the sport itself. Um, but in thinking about those things, you want to think about what is the object like? Is it blunt or is it sharp? The blunt ones are the balls, the rackets, body parts, and that causes that compressive force on the eye. And then there's the small and sharp ones. So we already talked about fish hooks. We do see a small handful of fish hook injuries every year. And then, and so, the thinking about prevention, it really is almost tailored to the individual sport and what you're doing with that sport. I know that there are some racket type related sports where a lot of the injuries are related when they play doubles and the one player is turning back and looking at their teammate, and then the ball hits them in the eye. And so, you think, well, for goggles, that's not very practical, but are you going to start telling patients, don't look back towards your partner ever? That's also maybe not so practical, but it's just interesting to think about those mechanisms. The one other thing is that, the size of the object is very important too. So a larger diameter object that fits outside the orbital walls or the orbital bones are going to transmit that force across the bones, and so less force to the eye, but an object such as a golf ball that fits within the orbit is going to transmit all that force directly into the eye. But a lot of things don't necessarily hit right into the orbit either. They glance off the side of the orbit. And so there's some times when you get hit, we have patients that get hit in the eye with a golf ball, and you think that's always going to be a terrible injury, but it just glances off the side. And so I don't necessarily think I answered your question per se, but I think it's hard to come up with, as far as eye protection goes, perhaps it's better topic for educating the public about how to best protect your eyes and to kind of think about these things a little bit to have it more forefront in the mind.
Yeah, I think that I really like how you talked about like a roots cause analysis. So when an injury comes in, what caused it and what factors could be changed to improve the outcome or have prevented the outcome. I am more
Yeah.
I am more familiar with basketball, and so I know that you talked about fourth quarter in the paint, and it's also going for a rebound. So someone's reaching for a rebound and then corneal abrasion off of the opponent's eye. I know that I've gotten people's eyes, I've gotten hit in the eye. And
Oh
so
no.
yeah, no, everything's been
Well,
fine. Go ahead.
here's a question for you then. Do you wear safety protective eyewear when you're playing basketball?
That is a great question. And before the podcast, I have not. And since the podcast, I haven't had much time to go play basketball. So far, undecided. But That's part of the podcast exploration, trying to convince myself to go and wear the eye protection.
Well, it's a process. It's difficult, I know.
Yeah.
Yeah.
So yeah, and I think that, that's something that like referees could look for, like rules can change if the public is convinced that it's a big enough problem, just maybe going off a little bit for basketball. There was the situation with HIV/AIDS was in the news, and just knowledge about blood products. And so now if anyone has any blood on their jersey anywhere, any blood, they're taken out of the game. And that's like rule, determined. And so, and that didn't happen before, but now public is very convinced that that is a necessary intervention for the sport. And so I think that there is room for the public to be convinced and for sports to change and adapt.
Oh yeah, certainly. Attitudes and ideas can change, certainly. I think, an example is the NHL too. There's a lot of resistance to wearing the visor, and then now it's mandated, and there's fairly good compliance. And even with the NFL, there's some longitudinal studies done, and they've shown that there's been increased use of eye protection in the NFL. Interesting, just like you said, it does seem like, at least that study that I looked at, was more common among certain positions, the positions that were more prone to injury. And then also some people have recommended mandating these things, or at least educating people about these things at a younger age. It's hard to get someone who's played without a visor all their life to start at age 20 or 25, but if you have them start in the little league, when they're 5 years old, and that's just kind of part of how, just like with the helmet, like, you just put your protective gear on. And so maybe we need to be focusing on the elementary ages.
Right. I think that's a great insight. I really appreciate your time tonight, Dr. Yu. Really appreciate it. Before you go, do you have a favorite sport or favorite sports team?
Well, it's been a pleasure to be on here. Thank you so much for inviting me. I'm very a geographical sports team person. So I now live in Seattle, of course. So I'm a big fan of the Seahawks and the Kraken. But for baseball, I did my training and lived for a long time in St. Louis. So I will always and forever be a Cardinals fan for baseball. But I will have to say that actually the sport that I enjoy watching the most is not any particular sport, but is actually the Olympics. Give me any sport on the Olympics, any at all, and I will love watching that. I just love watching it, summer and winter.
That's awesome. There was a recent article published with the Olympic Committee. I forget the title and the name. I'll send it to you after. But it was talking about eye injuries and Olympics, and coming up with a kind of standardized curriculum protocol. That was really interesting. So I'll put it put a link in there.
That sounds interesting because again, more research, things that we don't even know about, or we don't even know what we don't know. So that sounds fascinating.
All right, thanks, Dr. Yu.
All right, thank you so much. It's very enjoyable. I appreciate you doing the podcast. Spread the word.
Thank you for listening to Sports Ophthalmology. To stay connected and learn more, you can find us on Twitter, YouTube, and at our website, sportsophthalmology.com. Please don't forget to click on the link in the episode description to complete the 2-minute evaluation survey.